This is Chapter 24 of the ATI Maternal Newborn, Nursing Care of Newborns. Newborn care consists of stabilization and/or resuscitation. This can include establishing a patent airway, maintaining adequate oxygenation, and thermoregulation for the maintenance of body temperature. A physical assessment, physical examination, measurements, and monitoring laboratory studies is done every 8 hours or as needed. Nursing interventions and family teaching, umbilical cord care, prophylactic measures, newborn screening, newborn feedings and bathing, fostering baby-friendly activities are integrated into a newborn's plan of care. Physical assessment. Vital signs should be checked frequently following birth according to facility protocol or as indicated by the status of the newborn. Weight should be checked daily at the same time using the same scale. Inspect the umbilical cord, observe for any bleeding from the cord, and ensure that the cord is clamped securely to prevent hemorrhage. In the first 6 to 8 hours of life, as body systems stabilize and pass through periods of adjustment, observe for periods of reactivity. The first period of reactivity. The newborn is alert, exhibits exploring activity, makes sucking sounds, and has rapid heart rate and respiratory rate. Heart rate can be as high as 160 to 180, but will stabilize at a baseline of 100 to 120 during a period that lasts 30 minutes after birth. Period of relative inactivity. The newborn will become quiet and begin to rest and sleep. The heart rate and respirations will decrease, and this period will last from 60 to 100 minutes after birth. Second period of reactivity. The newborn reawakens, becomes responsive again, and often gags and chokes on mucus that has accumulated in the mouth. This period usually occurs 2 to 8 hours after birth and can last 10 minutes to several hours. Using the facility's preferred pain assessment tool, conduct a pain assessment on the newborn with routine assessments and following painful procedures. Lab test. Hemoglobin and hematocrit. Blood glucose for hypoglycemia per facility policy. Metabolic screening. A newborn genetic screening is mandated in all states. A capillary heel stick should be done 24 hours following birth. For results to be accurate, the newborn must have received formula or breast milk for at least 24 hours. If the newborn is discharged before 24 hours of age, the test should be repeated in 1 to 2 weeks. All states require testing for phenylketonuria, which is PKU. PKU is a deficit in protein metabolism in which the accumulation of the amino acid phenylalanine can result in developmental delays. Treatment in the first 2 months of life can prevent mental developmental delays. Other genetic testing that can be done included for galactosemia, cystic fibrosis, maple syrup urine disease, hypothyroidism, and sickle cell disease. Serum bilirubin on all newborns prior to discharge, and collecting blood samples. Heel stick blood samples are obtained by the nurse who dons clean gloves. Warm the newborn's heel first to increase circulation. Cleanse the area with an appropriate antiseptic and allow for drying. A spring-activated lancet is used so that the skin incision is made quickly and painlessly. The outer aspect of the heel should be used, and the lancet should go no deeper than 2.4 millimeters to prevent necrotizing osteochondritis resulting from penetration of bone with the lancet. Follow facility protocol for specimen collection. Equipment to be used and labeled as specimens. Apply pressure with dry gauze. Do not use alcohol because it will cause bleeding to continue until bleeding stops, and cover with adhesive bandage. Cuddle and comfort the newborn when the procedure is completed to reassure the newborn and promote feelings of safety. Diagnostic procedures. Newborn hearing screening is required in most states. Newborns are screened so that the hearing impairments can be detected and treated early. Screening for critical congenital heart disease. Newborns are screened at 24 to 48 hours of age. Pulse oximetry testing can detect some congenital heart defects. The oxygen saturation is measured in the right foot and right hand. The nurse should recognize that a passing result in an oxygen sat greater than 95 in either extremity with less than 3% difference between the lower and upper extremities. Circumcision is the surgical removal of the foreskin of the penis. The newborn's family makes the choice regarding whether to circumcise depending on health, hygiene, and religion. Jewish male on 8th day after birth, tradition, culture, or social norms. Parents should make a well-informed decision in consultation with the provider. Circumcision should not be performed immediately following birth because the newborn's level of vitamin K is at a low point and the newborn would be at risk for hemorrhage. The newborn is also at increased risk for cold stress. Circumcision is usually performed within the first few days of life, but might be postponed due to cultural reasons or for preterm or medically unstable newborns. Health benefits: easier hygiene, decreased risk of STIs, decreased risk of penile cancer and cervical cancer in female partners. Possible risks: hemorrhage, infection, inflammation or stenosis of the urinary meatus, urethra fistula, adhesions or dehiscence of the skin, and concealed penis. Contraindications: hypospadias, abnormal positioning of the urethra on ventral undersurface of the penis, and epispadis as urethral canal terminates on dorsum of penis. Because of prepuce skin can be needed for surgical repair of the deficit. Family history of bleeding disorders and newborns who do not receive vitamin K, making them more likely to experience bleeding at the circumcision site. Pre-procedure: assess the newborn for the following: family history of bleeding, hypospadias or epispadias, ambiguous genitalia. This can include both male and female characteristics, and illness or infection. Nursing actions: obtain signed informed consent from parents. Gather and prepare supplies, administer medication as prescribed, assist with procedure, place the newborn on the restraining board, and provide a radiant heat source to prevent cold stress. Do not leave the newborn unattended. Have bulb syringe readily available. Comfort the newborn as needed. Document time and type of circumcision, amount of bleeding, and newborn voiding following procedure. Intra-procedure: anesthesia. Anesthesia is required for circumcision. Types of anesthesia include a ring block, dorsal penile nerve block, topical anesthetic, a euctic mixture of local anesthetics, and concentrated oral sucrose. Non-pharmacological methods is swaddling, non-nutritive sucking can be used to enhance pain management. Equipment for performing circumcision: Gomco, which is Yellen or Mogan clamp, Plastabell device. The provider applies the Gomco, which is the Yellen or Mogan clamp, to the penis, loosens the foreskin, and inserts the cone under the foreskin to provide a cutting surface for removal of the foreskin and protect the penis. Using the clamp reduces the amount of blood lost. The wound is covered with sterile petroleum gauze to prevent infection and control bleeding. The provider slides the Plastabell device between the foreskin and the glands of the penis. The provider ties a suture tightly around the foreskin at the coronal edge of the glands. This applies pressure as the excess foreskin is removed from the penis. After 5 to 7 days, the Plastabell drops off, leaving a clean, healed excision. No petroleum is used for circumcision with the Plastabell. Post-procedure: nursing assessment. Assess the newborn for the following: bleeding. Assess every 15 to 30 minutes for the first hour and then hourly for the next 4 to 6 hours. The first voiding. Nursing actions: remove the newborn from the restraining board and swaddle to provide comfort. Monitor for bleeding and voiding per facility protocol. Apply gauze lightly to the penis if bleeding or oozing is observed. Apply diapers loosely to prevent pressure on the circumcised area. Liquid acetaminophen 10 to 15 milligrams can be administered orally after the procedure and repeated every 4 to 6 hours as prescribed for a maximum of 30 to 45 milligrams per kilogram per day. Provide discharge instructions to the parents about manifestations of infection, comfort measures, medications, and when to notify the provider. Client education. A signed informed consent is needed. The newborn will not be able to be bottle fed for up to 2 to 3 hours prior to the procedure to prevent vomiting and aspiration based. Newborns can breastfeed until the procedure. The newborn is restrained on a board during the procedure. Keep the area clean, change the newborn's diaper at least every 4 hours, and clean the penis with warm water with each diaper change. With clamp procedures, apply petroleum jelly with each diaper change for at least 24 hours after the circumcision to keep the diaper from adhering to the penis. Avoid wrapping the penis in tight gauze, which can impair circulation to the glands. Do not give a tub bath until the circumcision is healed. Until then, trickle warm water gently over the penis. Notify the provider if there's any redness, discharge, swelling, strong odor, tenderness, decrease in urination, or excessive crying from the newborn. A film of yellowish mucus can form over the glands by day 2. Do not wash it off. Avoid using pre-moistened towelettes to clean the penis because they contain alcohol. The newborn can be fussy or can sleep for several hours after the circumcision. Provide comfort measures for 24 to 48 hours to include acetaminophen as prescribed. The circumcision should heal completely within a couple of weeks. Report any frank bleeding, foul-smelling drainage, or lack of voiding to the provider. Complications and nursing management. Hemorrhage. Monitor for bleeding. Provide gentle pressure on the penis using a small gauze square. Gel, foam, powder, or sponge can be applied to stop bleeding. If bleeding persists, notify the provider that a blood vessel might need to be ligated. Have a nurse continue to hold pressure until the provider arrives while another nurse prepares a circumcision tray and suture material. Cold stress and hypoglycemia. Monitor for excessive loss of heat resulting in increased respirations and lower body temperature. Swaddle and feed the newborn as soon as the procedure is over. Nursing care. Stabilize and or give resuscitation to the newborn. Respiratory complications. Monitor for clinical findings of respiratory complications. Bradyapnea, which is respirations less or equal to 30 a minute. Tachypnea is respirations greater or equal to 60 a minute. Abnormal breath sounds, expiratory grunting, crackles, or wheezes. And respiratory distress is nasal flaring, retractions, grunting, grasping, labored breathing. Interventions for stabilization and resuscitation of airway. The newborn is able to clear most secretions in their airway passages. However, if the newborn is unable to clear the secretions, suctioning of the mouth and then the nasal passages with the bulb syringe can be done to remove excess mucus in the respiratory tract. Newborns delivered by cesarean both are most susceptible to fluid remaining in the lungs than newborns who were delivered vaginally. If bulb suctioning is unsuccessful, use mechanical suction to clear the airway. Institute emergency procedures if the airway does not clear. The bulb syringe should be kept with the newborn, and the newborn's family should be instructed on its use. Family members should be asked to perform a demonstration to show that they understand bulb syringe techniques. Compress bulb before insertion into one side of the mouth. Avoid center of the mouth to prevent stimulating gag reflex. Aspirate mouth first, one nostril, then second nostril. Identification. Using two identifiers is applied to the newborn immediately after birth by the nurse. It is an important safety measure to prevent the newborn from being given to the wrong parent, switched, or abducted. The newborn, client, and client's partner are identified by plastic identification wristbands with permanent locks that must be cut or be removed. Identification bands should include the newborn's name, sex, date, and time of birth, and client's health record number. The newborn should have one band placed on the ankle and one on the wrist. In addition to the newborn's footprints and client's thumbprints are taken, the above information is also included with the footprint sheet. Each time the newborn is given to the parents, the identification band should be verified against the client's identification band. All facility staff who assist in caring for the newborn are required to wear photo identification badges. The newborn is not to be given to anyone who does not have a photo ID badge that distinguishes that a person as a staff member of the facility maternal newborn unit. Many facilities have locked maternal newborn units that require staff to permit entrance or exit. Some facilities have a sensor device on the ID band or umbilical cord clamp that sounds an alarm if the newborn is removed from the facility. Thermoregulation. Thermoregulation provides a neutral thermal environment that helps a newborn maintain a normal core temperature with minimal oxygen consumption and caloric expenditure. A newborn has a relatively large surface to weight ratio, reduced metabolism per unit area, blood vessels close to the surface, and small amounts of insulation. The newborn keeps warm by metabolizing brown fat, which is unique to newborns, but only within a very narrow temperature range. Becoming chilled, cold stress can increase the newborn's oxygen demands and rapidly use up brown fat reserves. Therefore, monitoring temperature regulation is important. Monitor for hypothermia in the newborn. Auxiliary temperature of less than 97.7. Cyanosis, increased respiratory rate. Core temperatures vary within newborns, but it should be kept at approximately 97.7 to 98.6. Interventions to maintain thermoregulation. Heat loss occurs by four mechanisms: conduction, convection, evaporation, and radiation. Conduction is the loss of body heat resulting from a direct contact with a cooler surface. Preheat a radiant warmer, warm a stethoscope and other instruments, and pad a scale before weighing the newborn. The newborn should be placed directly on the parent's chest and covered with a warm blanket, and a cap should be placed on the newborn's head. Convection, flow of heat from the body surface to cooler environment air. Place the bassinet out of the direct line of a fan or air conditioning vent. Swaddle the newborn in a blanket and keep the head covered. Any procedure done with the newborn uncovered should be performed under a radiant heat source. Keep ambient temperatures of the nursery or client's room at 72 to 78 degrees. Evaporation, loss of heat as surface liquid is converted to vapor. Gently rub the newborn dry with a warm, sterile blanket, adhering to standard precautions immediately after birth. If thermal regulation is unstable, postpone the initial bath until the newborn's skin temperature is 97.7. When bathing, expose only one body part at a time, washing and drying thoroughly. Radiation, loss of heat from the body surface to a cooler solid surface that is close but not in direct contact. Keep the newborn and examining tables away from windows and air conditioners. Temperature stabilizes at 98.6 within 12 hours after birth if chilling is prevented. The best method for promoting and maintaining the newborn's temperature is early skin-to-skin contact with the parent. Bathing can begin once the newborn's temperature has stabilized to at least 97.7. A complete sponge bath should be postponed until thermal regulation stabilizes. Gloves should be worn until the newborn's first bath to avoid exposure to body secretions. Feedings can be started immediately following birth. Breastfeeding is initiated as soon as possible after birth as part of baby-friendly initiatives. Formula feeding usually is started at about 2 to 4 hours of age. The newborn is fed on demand, which is normally every 3 to 4 hours for bottle-fed newborns and more frequently for breastfed newborns. Monitor and document feedings per facility protocol. Sleep. Sleep-wake states are variations of consciousness and the newborn consisting of 6 states along the continuum, comprised of deep sleep, light sleep, drowsy, quiet alert, active alert, and crying. Newborns sleep approximately 16 to 19 hours a day, with periods of wakefulness gradually increasing. Newborns are positioned supine, which is safe sleep, to decrease the incidence of SIDS, or sudden unexpected infant death. No bumper pads, loose linens, or toys should be placed in the bassinet. Parents should sleep in close proximity, but not in a shared space. Higher incidence rates are noted for SUID or SIDS and suffocation with bed sharing or co-sleeping. Educate parents about the needs for immunizations as a measure to prevent SUID. Elimination. Monitor elimination habits. Newborns should void once within 24 hours of birth. They should void 6 to 8 times per 24 hours after day 4. Meconium should be passed within the first 24 hours to 48 hours after birth. The newborn will then continue to pass stool 3 to 4 times a day, depending on whether they are being breast or bottle fed. The stools of newborns who are breastfed can appear yellow and seedy. They should have at least 3 stools per day for the first month. These stools are lighter in color and looser than the stools of a newborn who are formula fed. Monitor and document output. Keep the perineal area clean and dry. The ammonia in urine is irritating to the skin and can cause diaper rash. After each diaper change, cleanse the perineal area with clear water or water with a mild soap. Diaper wipes with alcohol should be avoided. Pat dry and apply triple antibiotic ointment, petroleum jelly, or zinc oxide depending on facility protocol. Infection control. Infection control is essential in preventing cross-contamination from newborn to newborn and between newborn and staff. Newborns are at risk for infection during the first few months of life because of immature immune systems. Provide individual bassinets equipped with diapers, t-shirts, and bathing supplies. All personnel who care for a newborn should scrub with antimicrobial soap from elbows to fingertips before entering the nursery. In between care of the newborn, the nurse should follow facility hygiene protocols. Cover gowns or special uniforms are used to avoid direct contact with clothes. Family education. Provide family education and promote family newborn attachment. Provide family education while performing all nursing care. Encourage family involvement, allowing the parent and family to perform newborn care with direct supervision and support by the nurse. Encourage parents and family to hold the newborn so that they can experience eye-to-eye contact and interaction. Foster sibling interaction in newborn care. Umbilical cord care. The goal of the cord care is to prevent or decrease risk for infection and hemorrhage. Nursing actions. Cord clamp stays in place for 24 to 48 hours. Recommendations for cord care include cleaning the cord with water, using cleansers sparingly if needed to remove debris during the initial bath of the newborn. Assess stunt and base of cord for erythema, edema, and drainage with each diaper change. The newborn's diaper should be folded down and away from the umbilical stump. Bathing newborn by submerging in water should not occur until the cord has fallen off. Most cords fall off within the first 10 to 14 days. Medications. Erythromycin. Prophylactic eye care is mandatory installation of antibiotic ointment into the eyes to prevent ophthalmia neonatum. Infections can be transmitted during descent through the birth canal. Ophthalmia neonatum is caused by Neisseria gonorrhea or chlamydia and can cause blindness. Nursing action. Use a single dose unit to avoid cross-contamination. Apply a 1 to 2 centimeter ribbon of ointment to the lower conjunctival sac of each eye, starting from the inner canthus and moving outward. A possible side effect is chemical conjunctivitis, causing redness, swelling, drainage, and temporarily blurred vision for 24 to 48 hours. Reassure the parents that this will resolve on its own. Application can be delayed for 1 hour after birth to facilitate baby-friendly activities during the first period of newborn reactivity. Vitamin K, phytonadione, administered to prevent hemorrhagic disorders. Vitamin K is not produced in the GI tract of the newborn until around day 7. Vitamin K is produced in the colon by bacteria once formula or breast milk is introduced. Nursing actions. Administer 0.5 to 1 milligram intramuscularly into the vastus lateralis, where muscle development is adequate, soon after birth. Hepatitis B immunization provides protection against Hep B. Nursing actions. Recommended to be administered to all newborns. Informed consent must be obtained. For newborns born to healthy clients, recommended dosage schedule is at birth, 1 month and 6 months. For parents infected with Hep B immunoglobulin and the hepatitis B vaccine are given within 12 hours of birth. The Hep B vaccine is given alone at 1 month, 2 month, and month 12. It is important not to give the vitamin K and Hep B injections in the same thigh. Complications. Cold stress. Ineffective thermal regulation can lead to hypoxia, acidosis, and hypoglycemia. Newborns who have respiratory distress are at higher risk for hypothermia. Nursing actions. Monitor for manifestations of cold stress, skin pallor with mottling, and cyanotic trunk and tachypnea. The newborn should be warmed slowly over a period of 2 to 4 hours. Correct hypoxia by administering oxygen. Correct acidosis and hypoglycemia. Hypoglycemia, an initial drop in blood glucose after birth, is a common occurrence due to the cessation of the maternal supply of glucose. Blood glucose levels are not usually assessed in healthy-term newborns as they have adequate glycogen stores to compensate for the physiological change. A healthy-term newborn can tolerate an initial decrease in their blood glucose level to as low as 30. Newborns who have risk factors for hypoglycemia should have a blood glucose level checked within the first hour of birth. This includes newborns who are preterm, newborns who are small or large for gestational age, and newborns of diabetic clients. Interventions are indicated for at-risk newborns when their blood glucose levels are less than 40 to 45. Follow facility protocols regarding frequency of assessing blood glucose levels. Monitor for manifestations of hypoglycemia, jitteriness, tremors, weak or high-pitched cry, decreased tone, poor feeding, apnea, respiratory distress, low temperature, seizures, a blood glucose level than 40 to 45. Initiate feedings with breast milk or formula in clinically stable newborns to maintain or increase blood glucose levels. Continue to monitor blood glucose levels and feed every 2 to 3 hours for at least the first 24 of life and at-risk newborns and those who have demonstrated hypoglycemia as per facility protocol. Skin-to-skin contact will promote breastfeeding and thermoregulation to stabilize blood sugar levels. Hemorrhage is caused by improper cord care or placement of clamp. Nursing actions. Ensure that the clamp is tight. If seepage of blood is noted, a second clamp should be applied. Notify the provider if bleeding continues.